So welcome everybody again. I'm Dave Ryan to our Cancer and COVID-19 Zoomcast series. Today we have a special treat again. They're all special treats on the Cancer COVID-19 podcast or Zoomcast series. So we're going to be talking with the nursing leadership in the ambulatory setting of the Cancer Center. And the head nurse for that, the person who runs our ambulatory nursing program, is Erika Rosato, who has an enormous job overseeing all of the nursing operations in the Cancer Center, in the ambulatory component of the Cancer Center. And back before COVID, we were seeing probably about 1,000 people a day, roughly, were coming through the Cancer Center, just in terms of the hematology oncology, radiation oncology, and the surgeons who are located in Yawkey. But if you include all of the cancer patients throughout the entire Massachusetts General Hospital ambulatory program, it's well over 1,000 folks coming in each day. And so it's an enormous operation, and Erika's put together a phenomenal team, and I'm going to let Erika introduce you to all of them. So Erika.
Thank you, Dave. And they are phenomenal. We have half of our team here this week, and then next week we're going to have the other half, because it is a large team, because we've got a lot of nurses out there and support staff that need this incredible leadership that you're going to hear from today. I just want to give a shout out at this time, though. It is Nurses Week and Oncology Nurses Month, and that means a lot to us as leaders and also to our staff. So a big shout out to all those amazing nurses out there. Thank you for all the care you've given our patients, the care you've given each other, especially during this time of the COVID crisis. We've all relied on one another. That's how we've gotten through and how we're going to continue to come out good on the other end. So I'd like to start off and introduce our team members for today that are going to be speaking to us. Julie Cronin is our Nurse Director of Infusion. Then we have Caryn Liebowitz, who is our Nurse Director of Ambulatory Practice, who has been with us for now 3 weeks, Caryn, I believe. Newly hired and came to us during the crisis. And then we have Casandra McIntyre, who is the Nurse Director of the Termeer Center for Targeted Therapies. So thank you so much for being here today.
You're welcome.
So what questions do you have for us, Dave?
So I guess the first question is, for each of you, how did the COVID crisis affect the operations of your unit? And what was the timeline of those particular changes? Maybe we'll start with Julie, because Julie runs the infusion unit on Yawkey 8.
Yeah. So thank you for having us. As Erika said, I've been the nurse director for infusion it'll be 2 years in July. So it's been an interesting couple of years, and especially interesting the last few months. I think, it's just fascinating. Some days I think we feels like we've been doing this work forever in the middle of this pandemic, and other days it just feels like we just started. But there's definitely been a few steps in the timeline that I can try to outline for you. So I think in the beginning, what we found the most challenging is really the volume of patients that we see coming into the infusion unit. So prior to COVID, we were treating about 130 to 180 patients every day. And now, even in the middle of the pandemic, we're continuing to see very high volumes of cancer patients that need to come to our cancer center for treatment. So one of the things initially that was challenging was just the volume of patients, and really getting down those pointed assessments and trying to understand what was potentially COVID as we tried to understand more about the disease and the pandemic in general. And so trying to get those assessments of what could be COVID and what was just due to an oncologic process. One of the things that we did initially, and we're proud of as a best practice, was we had a nurse screen at the front desk all of the patients that were coming through. And so 130 to 180 a day, that took a lot of work, but this nurse was very seasoned and experienced, so she was comfortable with that. And working with those primary teams to really get down to that nuanced symptom. So we felt like that was a best practice, and kind of right out of the gate felt like we were a step ahead in that arena, which was great. And then I think working with the VPODs, which perhaps Casandra can describe a little bit more in detail, the APP.
Yeah, tell me what a VPOD stands for.
The VPOD is a viral provider of the day, and so that's really the APP group. So we worked with them very closely, an incredibly collaborative group. and really just try to identify a pathway and a process for those patients that were presenting with these new viral respiratory symptoms, identifying a safe pathway that they could come to Yawkey 8 for their workup and assessment. So that would entail working with the VPODs, and then they would work directly with their individual disease teams to bring these patients safely into Yawkey 8 so they could have their workup. And then from there, we would determine with the, sorry for the dinging, we would determine, next steps based on working with biothreats. If they needed to be admitted, go to the emergency department. So that was a really great collaboration. And then I think sort of next step was the deployment. So as we heard about the surge that was coming and the need for inpatient and ICU, we felt like we needed to do whatever we could to support that inpatient surge and need. So the infusion unit alone deployed 14 nurses initially, and that was, looking back, only I think the beginning of April. So interestingly, not that long ago, but we sent 14 nurses to the ICUs, the emergency department, and London 9 and 10 to be able to support those operations as much as we could. Also with balancing, again, still keeping a busy infusion unit open. So we're continuing that work now. And then Casandra and I and our teams and the VPODs worked on helping to create this rack infusion. So as things moved along the last month or two, we really wanted to identify a safe place where patients now COVID positive could receive their cancer care and their infusion. So that's kind of where we are, and I'll let Casandra talk more about the rack infusion, but I think overall it's just felt like, a few steps has led us to where we are now, and we're talking about re-entry and unsurging the surge, which will be our next phase.
So just for the audience, the viral provider of the day was an incredibly creative way to respond to the crisis, because so the APPs, which stands for Advanced Practice Providers, that can constitute both either a nurse practitioner or a physician's assistant. We tend to have in the Ambulatory Cancer Center, most of our APPs are nurse practitioners, but we felt like we needed somebody who was expert in evaluating patient symptoms, somebody who's coming into the cancer center with really problems. And a lot of the same symptoms of COVID are the same symptoms you get from cancer or your chemotherapy, whether that's a fever, a cough, some shortness of breath. So many of our patients who are actively being treated actually have, quote, COVID symptomatology, even though we probably knew in the back of our head that they probably weren't COVID positive, but we couldn't be sure. And then that's when I think we needed a place to take, not only a provider to take care of them, we needed a place to evaluate them, because when somebody comes in with active symptoms, you often have to get blood work, a chest x-ray, you may have to start antibiotics, and on and on. So Casandra, how did that transition when Julie came to you and said, hey, we have this problem, you stood up this VPOD, this viral provider of the day, but now we need a place to take care of them, and Yawkey 8 may not be the best place. Like, how does that happen?
Yeah, we had a lot of really great discussions, because she was having patients show up in the busy infusion unit on Yawkey 8, and it's crowded up there, and we were concerned that COVID positive patients might be too close to patients that didn't have COVID. So it became clear that we needed to carve out a space, and it would be best if the rooms were all private, because we might have a ruling out COVID patient and a patient who was COVID positive right next door to each other. So after a lot of discussion, which felt like weeks, but actually was only a week, we decided that Termeer was the best place for that, because I have 9 rooms that are private that the doors can close. I have 10 rooms, but one doesn't have a closing door. So when I look back at the timeline in preparation for this chat we're having today, we redeployed, Julie and myself and Caryn redeployed our nurses inpatient the first week of April. And we opened the rack on the 7th of April. So it really went very quickly. I sent a quarter of my staff inpatient, and then the next week we opened the rack. And so what we did was, Termeer is normally the place where we do first-in-human trials for research on new cancer therapies. And that's why all the rooms are private, and it's a tight little unit where you can lay eyes on everybody at the same time. we moved about a third of my staff with the clinical trial patients up to a section of Julie's floor, and they were warmly welcomed by the nurses up there. And so we continued treating those patients for research on that floor, and then we turned overnight the Termeer space into the rack infusion. And so what happens for rack infusion, and the VPOD came down here, so that's a couple of nurse practitioners and a couple of RNs who work on getting the banners cleared off of patients if they're COVID risk.
Yeah, describe that for the patients who are listening, or the MGH folks who are listening. What is a banner, getting a banner cleared?
Right. So in Epic, in our computer system, there's a banner that is put on your chart if you have been exposed to COVID. So that could be either from a family member or maybe from a clinician when you were in the hospital, if you had any exposure. So that's one banner. Another one is called COVID risk, and that banner is put up when we've tested you for COVID, but we don't yet know the results. Or you might be negative, but we want to test you again. Another banner is COVID positive, so you've been tested and you have a COVID diagnosis. And then there's COVID presumed, which is a new banner for that's mostly used inpatient for patients who have tested negative but seem to have all the symptoms. So we're kind of presuming that they might have it even though their initial test was negative. So once a banner is on a patient's chart, they really need to come to us for treatment. But they might be COVID negative. And so there's a team of the VPODs dig into the chart, read about the patient, read about their symptoms, and the RN on the team, Suzanne and Adrian, they attempt to schedule the patient for another swab in an outside facility, try to get the patient's banner cleared so that they can go back to be treated on Yaki 8 in their home infusion space. But if they're not, then they come to us, and we developed a really clear pathway for how they would arrive at the hospital, how they would come up one set of elevators and come directly to our unit. And often our nurses actually go down to meet them, either in the garage or on the first floor, and guide them up. The nurses on this unit are a combination of a third of my staff and some nurses that Julie has sent down to work with them. So it's a combined unit. They work together super well. They're a very happy bunch of people, and they're really unified around this common purpose of let's take the best care possible that we can for these people who have COVID. They're terrified, most of them, when they arrive, and let's just get them through their care, give them, what they need, if it's their chemotherapy treatment, or maybe they just need fluids, or we're working them up to see if they have further symptoms, chest x-rays, blood work. And now, as of last week, we're able to swab them here so that we don't have to send them to an outside facility to be swabbed. And we're seeing a full range of people. Some people are really sick, and actually we need to admit them. Others have very few symptoms, and we give them their chemo and they go home. But it's all
So,
to kind of...
Can I ask you a question?
Yeah.
Are we giving chemotherapy to COVID positive patients or COVID presumed patients if they have no symptoms?
Yes. So it's kind of it's the risk versus the benefits. If it benefits the patient to keep getting their cancer treatment, and we don't think it's a major risk because their COVID symptoms are very mild, then we're going to treat them because we want to keep treating people and giving them their often life-saving cancer treatments. But of course, if they have full-blown COVID symptoms, then we're holding them. And so we'll sometimes evaluate patients and say, yeah, it doesn't look like you should get your cancer treatment this week, but maybe you can come back next week and we'll see how you're doing. So that's the kind of care that we're offering here.
So it's almost like a great transition out to Caryn, because there's a whole bunch of patients. The hospital came to us, right, Erika, and said, hey, what about us? What about everybody else who doesn't have cancer? And how are we going to take care of them? And there's a lot of people who don't need infusion, but just need to come in for the practice. And it doesn't make sense to take up the whole, let's say, the whole infusion unit requirements in the Termeer Center for these COVID positive patients. So we then came up with the concept, or you came up with the concept, Erika, of the rack. And do you want to describe what the rack is? And then Caryn, maybe you can describe how the operations of it go. So first off, RAC stands for Routine Ambulatory Care for the COVID Patient, RACC, correct? Or
Absolutely.
something like that.
Yeah, you got it, Dave. Okay. And so on this clinic, which was our old 7B space, we created the space so that any ambulatory care provider could come in and see a patient that needed to be seen for an office visit.
Throughout all of Mass General.
You got it. So we've had, well, I'm gonna let Caryn speak to that, but we've had all different types of providers in there. We put together basically the whole framework of how it was gonna be done with the ambulatory management team, and they were wonderful to work with. And then we provided the staff to staff basically phlebotomy, front desk, medical assistants, some nurses, so that they would have people around them to, when they came into the unit, they have to wear their personal protective equipment. And so you need people to like watch people as they get donned, they put on their gowns and all their protective equipment and doffed. And so we had all of that staff there ready to go. We said, we are in, we will help with this process. And then these teams come in and they bring some of their own staff. If they have a special procedure they're doing, they bring in their own medical assistant or their own nurse, because there's no way we could train up our oncology nurses to be experts in all of those clinics. So Caryn, do you want to speak more about what you've been seeing in that rack?
Yes, certainly. And I just want to give a shout out to Ronnie Woods, who's unable to be on this video call today. She really is the initiator of the rack and put a lot of hard work into it prior to my arrival. So it's running very smoothly thanks to her great efforts. It is a great clinic. What we've done is we have, a certain area of several exam rooms, and we're seeing all sorts of specialties throughout the hospital, not just cancer patients, which ranges really from OBGYN, pediatrics, and then we have our cancer patients that come in. Like Erika said, we've asked the clinics to bring their staff with them to actually perform the exams and do any kind of procedures or medications that need to be done for their particular patients in the exam room. We are helping with monitoring in the hallways, like Erika said, donning and doffing, making sure that the rooms are cleaned appropriately afterward, and we provide phlebotomy and vital signs as soon as the patient comes in. And just like Casandra said, we follow the same pathway of getting the patient from the parking garage or however they're getting to the hospital up to their appropriate floor, so that they are not kind of co-mixing with the regular, the non-COVID staff or patients throughout the hospital. So ambulatory management really took that on and developed that whole process, and it seems to be working very well. We're probably seeing an average of maybe 8 patients right now a day. Mm-hmm. We expect that that's going to grow. And we also have this Hexapod that we put in outside of the clinic area. It's in its own space, and the Hexapod is a way for a nurse to be inside of an enclosed plexiglass space, and they use the plastic arms that come from the inside to the outside so that they can swab patients for COVID very rapidly without the nurse having to wear PPE. So the patients just come up, they get their swab, and they leave, and then we clean it with somebody donned in PPE after that's done. But it's just a way to get people in there pretty quickly without having to constantly change PPE per patient. So it's just protective of patients and staff. So that's been working really well also. It's exciting to have that.
And that's incredibly important, because the viral swabs, the nasopharyngeal swabs, are the gold standard for diagnosing COVID. Even though the blood tests are coming, they're not here yet. They're here a little bit, but we hope that we have them fully operational in the next month or so. But even if those get fully operational, you still have to know if people are infectious and are shedding virus, and that's why the nasopharyngeal swabs are here to stay. So let me shift a little bit, and let me ask each of you, what is the biggest stressor, both on the nursing management side of your job and the biggest stressor you see to patients? And let me start with we'll finish with Erika because Erika is the leader. So we'll get Erika's opinion at the end. But let's start with Caryn actually first. Caryn, give us, you're the newest member of the group here. Give us the biggest stressor that you've experienced, and then the biggest stressor that your patients that you see patients are having in your unit.
I think the biggest stressor for the patients right now is, just their concern. Patients who are not COVID positive coming to a facility that does have COVID positive patients. And when you're not here and you're not part of the medical team and people who know the backstory to all of this and how things work, coming in from the outside, I think it's a little stressful for patients thinking they're coming into an environment where they may get this virus. And we know that that's not going to happen because we have everything down, to a T, is keeping everybody separate. But I think that's probably the biggest stressor that I've seen for the patients. I think on the staff, it's like everybody else in the world right now, things change so quickly. So one day or 1 hour you hear one thing and then that may change very quickly. And I think that that's probably the biggest stressor for everybody is we think we're doing it this way now, but now we have to change it, and
Right.
Deployment and all of that kind of stuff, I think, is the stressor. So that's what I would say.
Yeah, I would agree. For the patients, what I found to be very, I don't know if it's comforting, but when I tell them in some communities, probably 30% of the people who are walking around have COVID, have had or have it right now. And so, so far, you're absolutely right. The amount of PPE that we wear and interact with people, the rates seem to be lower in the Mass General staff than the community at large. Casandra, how about you? Stressors on the patient and stressor on your staff.
So in my area, the stressors on the patients that I see, the patients that are arriving with COVID, are really high. They sometimes arrive sick and they're being dropped off by a family member, and the family member is not sure when they're going to see this patient again because we might end up admitting them. So that's a really...
Explain that, the visitor policy. So
families
can't come with them, huh?
No. So one of the first things we did in trying to kind of decrease the exposure of potential patients that might have COVID, or family members that might have COVID, or we just said no more visitors allowed in the cancer center and in the hospital as a whole. And that's not a decision that we made lightly. It's very, very hard for us to see patients not have their family members with them. It's heartbreaking. But we really felt like in order to keep those family members safe, to keep our staff safe from further exposures, we really had to make that rule. And so we're trying as best we can to support families and patients through that. But we'll have for example, a wife drop a husband off and he was having a hard time breathing. And when the staff went down to get him out of the car, she was just in tears, wondering if he was going to get admitted, and if so, when she would see him again. Thankfully for him, we didn't have to admit him, and he went home that night, and she was in tears again with joy. We had another patient who, after coming to our unit, we realized that he had progressed in his cancer beyond his clinical trial, and we didn't really have another option for him. So we had to have a discussion about sending him home on hospice. And we had been treating this patient actually for a long time in Termeer. So it was very sad for the nurses. We had to have that conversation with him and his wife and the provider on an iPhone in the room. So that was really tough. And then when the nurse took the patient down to the car to put him in the car, the wife wanted a hug from a nurse that she had known for a long time. And it was really tough for that nurse to not be able to hug the wife. Thankfully, he actually tested negative for COVID, and we were really happy to hear that because it meant that his family could come and visit him and be around him at this time. So those are some of the stressors that both patients and the nurses who care for those patients are going through. And I think the other big stress that my team is having is that we're all over the place. So I have a quarter of my staff deployed inpatient,
Right.
and I'm trying to kind of keep up with them by texting them and giving them little encouragements, but they feel a little disconnected. I have a group of my staff upstairs on Yaqui 8 taking care of research patients, and I have another group down here taking care of COVID patients. And then I have a group of research nurses who are working half and half. Some are working at home, working on protocols and sending, communicating with patients from afar. And some are here on site trying to keep the research part of our efforts going. So they're all spread out and they miss each other, and that's a stressor. But we're doing our best.
And Julie, how about you?
Yeah, so similar to Caryn and Casandra, I think we're definitely experiencing all of those things. I think it's so interesting. It's Nurses Week and the Year of the Nurse, and I think there's definitely an art and a science to nursing. Right now, it feels like that science piece, the data and the research and the science that we're so used to being able to speak to and be experts in cancer care, we're kind of missing that. There's just so many unknowns. So as a nurse, you want to be able to answer questions, and you know what to expect and you anticipate. And right now, there's just so much change and so many unknowns that it's just a level of discomfort that we've grown accustomed to over the past few weeks, but we don't have the answers that we want to. So I think that's really tough for us. That science piece, like I said, the data and the research, we just don't have it. So we struggle with that a little bit. And to Cassandra's point, with the redeployments and, our nurses, a lot of them are parents. They're trying to homeschool their children, and they keep showing up to work every day. They're so strong and so resilient. I'm just amazed by them all the time, that they can come to work and put their best faces forward for these patients, despite what's going on in home. And it's hard for all of them. And then in terms of the patients, I think the change, and I think just the unknown again, they first were hit with having a cancer diagnosis, and now they have to worry about COVID on top of this, and it just seems so unfair. So,
right.
They worry about coming into the cancer center, and I think what's been really great is with collaborating with Cassandra's group, we can message to them and say we have a safe place and a safe pathway, and we're able to give you whatever care you need. So please report your symptoms to us truthfully, because we will work with your disease team and we will figure out exactly the care that you need. So, there's a lot of stressors, but those are cool.
And Erika, how about from a leadership perspective? How about what's the biggest stressor for you?
I think definitely the biggest stressor for me is when you have to enact rules or guidelines or ask people to be deployed when you know how hard it is for them. So I'm still teared up, Casandra, from what you just said about that patient, but we're all incredible, caring human beings. And so even though we know we have to make these decisions, the right decision to make, for example, coming down hard on the visitor policy, that was hard. I remember talking to everyone about it and realizing that how difficult it was going to be for our patients and their families. And so our staff was amazing, and they said, we're going to do this. Of course, it's the right thing to do for all the reasons that Casandra and Julie and Caryn explained. And we did put people down in the front lobby to escort those patients who needed help up to the infusion, up to Termeer and up to the clinic. But it's hard. You make those decisions and you know the impact it's having. Deploying your nurses in one weekend, we ended up deploying 35 nurses over one weekend. We knew it was coming. We were prepared, but it was really hard. Friday afternoon, grouping together 8 of our nurse leaders together over a weekend and said, we got to do this. We got to do it now. The surge is coming. We've been asked. And knowing that these nurse leaders in front of you would be making the call to the staff, many of whom they had already prepared, they had talked to and said, this is coming. We were very transparent about that. But over a weekend saying, on Monday, you're going to report to duty in an ICU or in a general care unit or a respiratory illness clinic. And I think in your heart as a leader, and we're all leaders here, it's the right thing to do. It's what we need to do. But at the same time, it weighs heavy in your heart because you know the impact it's having on your staff, and on your patients and families. So I think every day we find the silver lining, which is the staff have been amazing. When we've asked them to do something, they have said, we will go, we will be deployed, we will help. We understand the visitor policy, we will escort our patients up. We'll work together, however to make this work. But I think it's also knowing that they're gonna come back. That's what gives us hope every day, is once we get through this, those staff that have been deployed, nurses and support staff, are gonna be back, and our family's gonna be united again. And I think it's just waiting for that day to come, So.
Well, you guys have been phenomenal at it, and I know your staff appreciates you and all the care and thought that goes into all of these hard decisions that you've had to make. I guess we only have 5 minutes left, and what I'd love to hear in the last few minutes is this enormous change that we've all gone through. Some of it'll go back to being the way it was, but some of it won't. We are definitely getting the feeling that things have changed for good in some way, just the way, like after 9/11, how things all changed and we got used to a new normal. In your world, what do you think is going to be the one thing that you think has definitely changed, is not going to go back to the way it was? And let's start with Caryn. What do you think, Caryn?
Well, I think going forward, we're going to have to pay a lot of attention to seasonal flu or seasonal COVID, and probably be prepared and have a setup for, if and when this continues to happen year after year, and have a plan so that we can take care of all the patients, whether they're COVID positive or not, and somehow get to a point where we can figure out a plan where they can possibly be commingled together, so that we don't have to have these separate type of units, and people won't be so afraid of coming back to MGH where, COVID patients were, and it'll just hopefully get to be kind of, not a great norm, but we'll get accustomed to it, and we'll, have the research behind it and the vaccines. And that's my hope, is to just get to a place where everybody's much more comfortable with this.
Casandra, how about you? When are we getting back to research, and what is what change is here to stay?
Well, I hope to get our research unit back by July 1st. That's my goal date. I don't know if that's going to work. I keep saying that date.
I know it's
really hard.
It's coming. And we've done a lot of things to change research, and we had to get permission from the Partners IRB for that, and it was really complicated, and sponsors had to work with us on actually not collecting quite as much data. I don't think that's here to stay. I think we need to collect all the data on all of our research, but we might be able to do some virtual visits with our physicians more frequently, which is convenient for the patient if they can stay home and have a virtual visit at home, and then have a little more flexibility around when they come in for their data points. What I really hope stays with Mass General as a whole is how creative and quickly we have adapted and changed. It used to take a year to get one policy passed, and man, it doesn't take that anymore. We've moved really quickly, and we've shown that we can do that, and I hope that innovation and that creativity stays with us.
Great point. Julie.
Yeah, I totally agree with Casandra, and I think, so one of the things I think will be staying is that we should be fully operational 7 days a week. I don't ever see us going back to pre-COVID time. So I think that presents a unique opportunity for patients, and especially if we capitalize on the use of telehealth and virtual visits, that these patients could potentially receive a telehealth visit in their home and choose any day of the week that they want to come to our infusion unit and get their treatment. So I think that's a unique opportunity. And as Casandra said, I think it's a really great time to be able to pause, even though it's so crazy and busy and stressful, that we do pause and come together as an interdisciplinary group and really look at new ways of doing things. We have a great opportunity to do that now. So we have a task force set up, and we're going to get that going. And I just think that there's a few things that we can be doing different and better post COVID in our new normal.
And Erika, we'll give you the last word. So you run this enormous operation here at Mass General. What do you think most excited about in terms of the change that's here to stay?
Most excited about, I think these ladies just said a lot of what I would say. So I would say what really was amazing through this journey, and we're not out of it yet, was a sense of real community. So community of us all coming together, but not just in Boston, but in Waltham and in Danvers and in Newton Wellesley, and how everyone just said, how can we help? How can we make this work? And how can we as a cancer center support what's going on within our cancer center and also at the main hospital? And I just hope that sense of community and coming together, we are so united that, you know, people don't go back into their spaces, that everyone still stays that nice connection, which I do believe will happen. We formed some really amazing, stronger ties with one another, and it's been that's been the silver lining, definitely.
Well, I think we'll leave it on that. That's a great silver lining. And thank you to all of you and to your entire staffs and everything that you guys do. You are a testament to the best that MGH has ever had. And going forward, I'm sure you're setting the example for the next generation, because the work you've done has just been incredible. So thank you a ton and have a great rest of the week.
Thank you, Dave.
Dave.
Thank